Welcome to the Varelaze Endovenous Laser Therapy clinical instruction video. This video will provide you a step-by-step overview of an endovenous laser therapy procedure using the Varelaze laser console and disposable supplies. The Varelaze procedure begins with an ultrasound examination of the patient in the standing position. The physician notes the anatomy and location of the great saphenous vein and any perforating veins connecting to it. The great saphenous vein can easily be identified under ultrasound in the short axis view because of its position between two fascial planes. To determine reflux, the ultrasound probe is positioned in the long axis view and pressure is applied to the limb. Reflux greater than a half second is considered significant pathology. This is demonstrated both in the analog waveform as well as with color flow Doppler. Once the physician determines there is clinically significant venous reflux, the patient is scheduled for their outpatient endovenous laser procedure. On the day of the procedure, there are a number of sterile items you will need for the procedure. Almost all of these items are provided to you in the standard Varelaze procedure kits and procedure packs. We also provide a completely custom procedure kit and pack option to meet your specific clinical needs. Setting up the room is straightforward. After setting your sterile table, you will need to mix up a 500 milliliter bag of 0.1% lidocaine with epinephrine that will be used throughout the procedure. If you have a tumescent delivery pump, you will need to set that up as well. When the patient arrives for the procedure, ultrasound will again be used to identify the saphenofemoral junction and to map out the total length of the vein being treated. The physician will also determine their desired access site on the leg. Once the patient has been scanned, the leg being treated is prepped and draped. Before gaining percutaneous access, a small dose of lidocaine is injected locally to numb the skin. Using ultrasound guidance, the physician gains percutaneous access into the vein. The physician knows they are intraluminal because of the presence of venous blood dripping from the needle. A 35 thousandths guide wire is then advanced up to and through the saphenofemoral junction. The Varelaze mark sheath and dilator are then advanced over the wire. The sheath is then advanced up to and through the saphenofemoral junction. The wire and dilator are then removed and the sheath is flushed. The Varelaze fiber is opened and passed off the sterile field. It is then attached into the laser's Quality Safe Connector, or QSC. The distal end of the fiber, with the aiming beam active, is inserted into the hub of the sheath. The fiber is then advanced until the first black mark on the fiber is flush with the sheath. The sheath is then pulled back and snapped securely into the end of the fiber lock. This positions the tip of the fiber 2.5 centimeters outside the sheath. Under ultrasound guidance, the tip of the fiber can be seen passing through the saphenofemoral junction. The physician withdraws the entire system until the tip of the sheath is approximately 2.5 centimeters from the terminal valve. When the laser tip is positioned in the great saphenous vein, the laser aiming beam can be seen transdermally. Using the autofill syringe or a tumescent anesthesia pump, such as the Klein pump, tumescent anesthesia is administered to keep the patient comfortable during the procedure, as well as to act like a heat sink to help insulate the vein. The 0.1% lidocaine solution is injected into the fascial plane using the autofill syringe or tumescent anesthesia pump. The fluid is held within the tissue and forms a halo around the vein. The tumescent anesthesia will track up the leg as much as 6 inches before the physician is required to reposition the needle. Once the patient is fully anesthetized, the Varelaze laser is set to 14 watts on continuous wave. If desired, the physician can also set the audible joules tone on the laser console, which will help with a steady and even pullback rate. Then, using the centimeter markers on the Varelaze sheath as a guide, as well as the audible joules tone on the laser console, the physician starts the laser and continuously pulls back at a rate of 1 centimeter every 5 seconds until the sheath is just a few centimeters from the skin surface. When the procedure is complete, the treated leg is cleaned and dressed with a bandage, wrapped with the dressing, and placed into a Class II compression stocking to be worn continuously for 48 hours without showering and then worn every day during the day for another week or per physician instruction. The patient is encouraged to walk frequently and take over-the-counter pain relief as needed for 1 week.